Basic microscopic semen analysis. Sperm count. The total number of spermatozoa per ejaculate and the sperm concentration is related to both time to pregnancy and pregnancy rates, and are predictors of fertility. However, more data correlating total sperm numbers with reproductive outcomes is warranted. The number of spermatozoa in the ejaculate is calculated from the concentration of spermatozoa and the ejaculate volume. For normal ejaculates, when the male tract is unobstructed and the abstinence short, the number of spermatozoa is correlated with testicular volume and should not be less than 39 million, and thus is a measure of the capacity of the testes to produce spermatozoa, the patency of the male tract, and, potentially, the number of spermatozoa transferred to the female during coitus. While the concentration of spermatozoa in the ejaculate is related to fertilization and pregnancy rates, it is influenced by the volume of the secretions from the seminal vesicles and prostate, and it does not represent a good measure of testicular function. Sperm concentration is the number of sperm per milliliter of semen. It is calculated manually or automatically from at least 2 counting slides. Normal sperm concentration is 15 million per ml. However, sperm concentration is more variable than total sperm count, since semen volume is mainly made up of secretions from the seminal vesicles and prostate. Sperm motility. Sperm motility is controlled by its complex structural and molecular signaling mechanisms. Broadly, spermatozoa are divided into 3 main parts: the head, which contains nuclear material; the tail, or flagellum, which includes the machinery needed to propel the spermatozoa forward; and the neck, or connecting piece, which contains the mitochondria, or energy production house. The pivotal part of the sperm flagellum is the axoneme, which originates at the connecting piece and terminates at the end piece. Human spermatozoa start motility in the seminiferous tubules and gain motility potential during their epididymal transit, which is around 2 to 11 days. During their transport and storage in the epididymis, spermatozoa undergo a series of physiological and biochemical changes to acquire fertilizing ability. Considering these facts, Chu has recommended 2 to 7 days as an ideal abstinence time for assessing the semen parameters. Sperm must swim distances over 1,000-fold their length, while contending with fluid viscosity, shear flows, and physical barriers. In sperm function studies, computer-aided sperm analysis, CASA, has proven successful in analyzing sperm motility. The motility types, according to the WHO 6th edition manuals, are 1. Rapidly progressive, 25 micrometers as, spermatozoa moving actively, either linearly or in a large circle, covering a distance from the starting point to the end point of at least 25 micrometer or a half-tail length in 1 second. 2. Slowly progressive, 5 to 25 micrometers ses. Spermatozoa moving actively, either linearly or in a large circle, covering a distance from the starting point to the end point of 5 to 25 micrometers, or at least 1 head length to less than a half tail length in 1 second. 3. Non-progressive, less than 5 micrometers. All other patterns of active tail movements with an absence of progression, i.e. swimming in small circles, the flagellar force displacing the head less than 5 1 head length from the starting point to the end point. 4. Immotile, no active tail movements. The progressive sperm movement occurs with the help of the tail's spiral movement, which creates thrust and pushes the sperm forward. Sperm vitality. Sperm vitality, as estimated by assessing the membrane integrity of the cells, can be determined routinely on all ejaculates, but is not necessary when at least 40% of spermatozoa are motile. In samples with poor motility, the vitality test is essential to discriminate between immotile dead sperm and immotile live sperm. A large proportion of live but immotile cells may indicate structural defects in the flagellum. A high percentage of immotile and dead cells may indicate epididymal pathology or an immunological reaction due to an infection. The rate of live spermatozoa is assessed by identifying those with an intact cell membrane by dye exclusion. Dead cells have damaged plasma membranes that allow entry of membrane impermeant stains, or by hypertonic swelling. Sperm morphology. The value of human sperm morphology assessment is not only the limited prognostic value regarding spontaneous pregnancies or outcome of ART, but even more the diagnostic information about the functional state of the male reproductive organs, primarily the testicles and epididymides. It is not sufficient to only determine the proportion of normal spermatozoa to evaluate the male reproductive organs. It is essential to assess the specific morphology of the head, neck, midpiece, and tail, and the possible presence of abnormal cytoplasmic residues. All human ejaculates contain spermatozoa with a wide range of different morphological appearances. Earlier definitions of sperm morphology were based primarily on experiences from veterinary medicine and microscope investigations. In some ways, the term normal spermatozoon is ambiguous, causing misunderstandings and even academic conflicts. Normal sperm is that it indicates that the cell or individual is not affected by the disease, but a normal morphology does not mean that the sperm cannot carry another cause of pathology, e.g. immotile tail or damaged DNA. The range of percentage normal forms for both fertile and infertile men is likely to be well under 30%. This will inevitably produce low thresholds discriminating between fertile and infertile populations. Indeed, reference limits and thresholds of 3 to 5% standard forms have been found in studies of in vitro fertilization, IVF, intrauterine insemination, IUI, and in vivo fertility. Furthermore, it should be emphasized that observed differences in group averages between infertile and subfertile men do not automatically mean that the calculated limits can be used to interpret results from individual men. The positive and negative predictive values must be determined to obtain valid such limits. This is difficult, for instance, when it concerns the proportion of normal or ideal or typical spermatozoa. Sperm clumping. There are two different types of sperm clumping that it is essential to assess separately. Sperm aggregates. The adherence either of immotile spermatozoa to each other or of motile spermatozoa to mucous strands, non-sperm cells or debris is defined as non-specific aggregation. Sperm agglutinates. Agglutination specifically refers to motile spermatozoa sticking to each other, head to head, tail to tail, or in a mixed way. The motility is often vigorous, with a frantic shaking motion, but sometimes the spermatozoa are so agglutinated that their motion is limited. Any motile spermatozoa that stick to each other by their heads, tails, or midpieces should be noted. Motile spermatozoa stuck to cells or debris, or immotile spermatozoa stuck to each other, aggregation, should not be scored as agglutination. The major type of agglutination, reflecting the degree and the site of attachment,